Esha and Robin, over to you.
Thank you, Dr. Mansuri. Just a second. Right. So our next speaker is Dr. Akhil Jain. So Dr. Jain is a third-year resident in internal medicine. He has had a phenomenal career spanning over 2 decades, including formal postgraduate and doctorate training in India before he moved to the US. Dr. Jain has been a great educator who loves to teach medicine to students and residents. He has contributed to enhancing and disseminating knowledge of internal medicine, addiction medicine, oncology, and cardiology. His extensive research experience and various publications and presentations at national and international conferences. Organizations like AHA CHEST have promoted his papers for new releases, prominent being Medscape, Yahoo, Fox News, amongst others. Welcome, Dr. Jain. I hand over the virtual stage to you now.
Yeah, thank you, Robin. Am I audible clearly?
Yes, sir. Loud and clear.
Okay, yeah. Hey, hi all. I'm a third-year resident at present at Mercy Catholic Medical Center. I will be giving you an overview of the NIS. NIS is a database, a United States database for the hospitalized patients. Okay. Can I share the screen? Yeah. Okay. So this is a research conference going on since morning, and important questions: why you need research, how to do research, and how to use this research to enhance your CV and to enhance yourself in your career. So why research? It's very obvious that you need to enhance your CV. Besides this, there are people who have genuine interest in the research, to give back to the science, to give back to the society. Why science? All these are the reasons for the researches. For USMLE, it is a part of the process. So the another question which most of the residency applicants ask, and the medical students also ask, when do I start the research? Now suppose this green dot is your start of the USMLE journey, and you keep on moving in your journey. Then in this part, anywhere in your journey, take the first black dot, second, third, fourth, anywhere you can start doing the research. So even if you are at the last black dot or maybe beyond that, don't have a FOMO of not starting the research so far. How to do the research? There are different research methodologies: the case reports series, collective review of the case reports. Then there are the surveys. Surveys are also very interesting kind of a research, where you put up the questionnaires using, and it not need to be the financially dependent. There are free survey methods available these days: SurveyMonkey, Google Form. They allow the survey questionnaires to be launched up to a limited number of the questions, which can itself be impactful in if there is an innovative question that you are asking. Then there is the original risk studies, review articles, trials, meta-analysis, and the systematic reviews. So the science of research is very well organized, how these researches are conducted and how these researches are organized in a hierarchy to go from the case reports up to the evidence-based guidelines. So talking of the original studies, we can either have the prospective or the retrospective ones. Prospectives are usually the observational, where you define your endpoint before starting of the study and you follow up the patients or lab values or something like this to identify your endpoint in the future. The retrospectives, as the name suggests, you go back and look into the data and pool the data or pool your cohorts or the outcomes from these cohorts. So National Inpatient Sample Database, this allows you to have the original studies, and that too in a retrospective manner. So what is NIS? So NIS is a database. There is an agency called Agency for Healthcare Research and the Quality, which has its project, which is called HCUP, Healthcare Cost and Utilization Project. And this HCUP project has number of databases in itself. NIS database is one of them. NIS N stands for either national or the nationwide. You can use any of these if you are writing any of the manuscript, but the recent one, I guess so, is the national inpatient sample that they're nomenclating. And these NIS database is then further divided into the data sets. For example, like 2015, 16, 17, each is a yearly data set. So this is the basic design of the AHRQ and how the NIS database is divided into the data sets. So giving you the overview of this is the largest publicly available data set for the inpatient population of the hospitalizations in the United States. Each year has more than 7 million hospital stays. That is the unweighted number that they give. If you weight that, it is 35 millions. Now there are difference between the unweighted and weighted, which you need to understand is that there is a weight variable in this data set, which allows you to multiply this unweighted numbers by some fraction, which will give you the weighted numbers or the weighted results in the statistical analysis, which simulates to the results of the US population, which you can generalize to the US population. NIS is a sample in an unweighted form. When you generalize it by applying the weights, it becomes generalizable to the United States population. So that's the advantage of using the weighted analysis. So this NIS data sets, they are available from, I think so, 1988 or 1998. I think it is 1988 up to 2020, which 2020 is recently released within the last month. And after 2012, there was redesigning in the sample data sets of all these. Before 2012, it was based, stratification was based mainly on the hospitals. Now it is based on the discharges. 20% stratified sample of all discharges from the United States community hospitals is there, but these exclude the rehabilitation and long-term acute care hospitals. So if I show you, this is the website, which I put the link there as well, where you can go and have an overview of the NIS, and you can read through this, how it is designed, and you can toggle through the various tabs here in the site to understand how the NIS is designed. I tried to simplify it in this 1 hour because it's a very tedious process, and it takes a lot in when you sit at the first and try to understand what's there in the NIS. So redesigning, I explained you, was in 2012. The another important point is this: the NIS database has in the recent years, if you see some of the recent publications, you will either see in the ICD-9 basis or the ICD-10 basis NIS publications. What is ICD-9 and ICD-10? I will explain you that as well. Okay, let's go to the ICD-9 and that first. International classification of diseases. So whenever patient is discharged, it is billed by the insurance companies, be it Medicare, Medicaid, private insurance, or by the hospital, private insurances, or the self-pay patients. So the diagnosis is given a code according to which they are billed. So these are called the international classification of diseases. Now, before October 2015, it was ICD-9, and after from October 2015 up till now, it is going on as a ICD-10. And when you apply these ICD-9 and ICD-10 in a corresponding data set, you will get the national yearly estimate for the healthcare utilization, cost, quality, and the outcomes that you define on hospital stays, regardless of the expected payer, because as I told, it includes the Medicare, Medicaid, private insurances, and the self-pay patients as well. So can you get NIS? Yes, you can yourself purchase INS. HCUP is the site that I showed you an HCUP overview. From there, you can get it done. You need to have some training for that. So training also, they are giving the option. There is a link there which allows you to have an online training, and once it's like something 15 to 30 minutes of training, and once you are done with that training, they ask you to sign a data user agreement, which is also available on the HCUP website. And once you sign that, submit that, then you can submit your request which database you want to purchase. So this is the site where you can go. This is the link where you can go and see the various databases that are available. This is the database catalog to start with. Here they give you option to register for an account, and then there is an option for the training course. It is approximately 15 minutes. Once you do, this is an online training course. Once you do this, it will generate a certificate for you. That certificate you always be needing to purchase any of these databases from the HCUP. These are the various databases that are available on the HCUP. NIS we are talking today. NIS is available in the different prices. If you are a student, if you can provide them with some proof for being the student, whatever they ask for, and if they are satisfied, they will allow you to have in the student prices. And there are, if you have any query, you can mail them or call them. Calling is usually longer, they hold you on a wait, but mailing is okay. They I have done a couple of times myself in the past for various queries, and they usually reply in 3 to 7 days most of the time. Besides NIS, you can have the various databases also from here, but let's concentrate for NIS for the time being, okay, and how the design of the NIS is. So NIS, as I told you, these are the yearly data sets. So it's an annual calendar year file. This NIS will be delivered to you in your inbox as a link, and from the link you go to the HCUP site and then download there. It is delivered as a 3 discharge level files and the 1 hospital level file. Core, severity, diagnosis, and procedures are the discharge level files, where the hospital is the hospital level file. After downloading, so it's a format, it's a very condensed format which they give you. It's a ASC2 formatted data files. Once you get that, it's a compressed file, so you need to decompress it, you need to extract the file. You should be having another software like WinZip or something to extract to open the this zipped file. Once you have the zipped file, you will be needing the password. The password, once you get the purchase approval, you will be delivered a password to your email, which is for you only to use, and you use that password to decompress the files and open the single file into the these 4 files that I showed you before. This is going to be very heavy files in GBs, many GBs. 2019, when I used that file and decompressed that file, and finally set the whole file, all the 4 components on all the 4 files together combined, it in the Stata software, it went more than 50 GBs. So it takes a lot of memory for the RAM, and your hard disk should also be having the memory, lot of memory to store these things. Then to run these files, so these files you cannot run on the Excel. First of all, you need to have some software, SAS, SPSS, data. These softwares, they give these 3 software specific files to decrypt or decompress these files and get into their workable format on the HCUP website. They give you the load program. Once you have these files and you decompress that after using the password, now the another question is how you get into the workable format for these files. So then you need to have a load programs. So if you see here, you have the load programs here for the various statistical softwares. According to the ease of use or whatever software you find user friendly, you will download the load program for there and you will follow the instructions, and then you will be uploading the ASC2 decompressed files to run with these load programs, and then you will get the final data format in a workable form. So once you get a workable format, then you see the lot of the elements which are actually the variables upon which you play with, upon which you build your research. So this is the link where you can just type NIS data elements or description of the data elements. You will get to this link, and here you see so many variables they have in this data sets. Okay, starting from A up to all through up to the Z. So I have uploaded this data set, and I use Stata most frequently. This is the Stata software interface of that Stata software. If you don't know any of the softwares, I find it very user friendly. That's why I use it most often. And if you look here in the variable section, these are the variables that are generated after this. Okay, these are all the variables that you have. This is the 5% of the data set that I've derived just for the demonstration that I uploaded here. And these are the various variables we have it now to build our research. So first of all, more important, how to use the ICD-10 data sets for the here. So once you go here, I'll open it again. So now you need to have some diagnosis upon which you will be building your research. So in the ICD-10 data sets, that is 2016 to 2020, you will find under the name I10_DX. You see here, it gives you all of these discharge diagnosis. These are the discharge diagnosis. I10DX means I10 is for the ICD-10, the DX is the discharge diagnosis. That is when the patient is being discharged, then patient is giving the primary diagnosis, why he or she was admitted in the hospital, and the secondary diagnosis, what are the associated conditions or the comorbidities that patient had. These are based on the ICD-10 CM classification. CM means the clinical modification, which gives you diagnosis like acute heart failure, acute myocardial infarction, stroke, sepsis, septic shock. All these are the ICD-10. Then next you have here ICI-10-PR1s. In the ITER-PR1s, you get the procedures. What were the procedures performed while the patient was admitted in during that hospital stay. So ICD-10, how do you choose? Suppose you need to choose STEMI. So just Google STEMI ICD data and codes. The site which I find most useful to use is the icd10data.com. I go, it takes me there. You will find such interface there. And you see here, there is a disease of the circulatory system, I00 to I99. You click on that, it will take you to this section. And here you will see the ischemic heart disease, I20 to I25. Let's say I20 to I25. And once you click over there, it will take you further to the myocardial infarction, I21. You click it here. It will take you further to the STEMI. And then you use these codes to generate your variable for the STEMI. So once you generate the codes, it is usually in any of the software, this is common for all the softwares, you generate the codes with the 0 and the 1. 0 for being absent and 1 for being present. Though you can reverse also, but it is easy to use 0 and 1 for 0 being absent and 1 being present. Similarly, for the procedure code, suppose you need to have coronary artery dilatation codes, then you search for the Google, take the ICD-10 PCS codes, and from here choose the first one, medical and the surgical. Click that, you will come here, you will get 02 heart and the great vessels. From there, come to the dilatation 027 and choose the first one, coronary artery. If you want one artery, two artery, three artery, four or more arteries, if you want all, then you need to combine all the codes while developing the coding. Then you get all the codes here, and then the procedure starts from here in the coding, that you take these codes, you take this ICD-10 PCS codes. PCS means the procedure coding system codes to the statistical software to build your variable over there. Now these are for the diagnosis. Now it comes to the comorbidities. After 2019, HCUP itself gives a beautiful software, that is a Alexander comorbidity software. Let me go to this link. So this is the Alexander comorbidity software, which you can again download from the HCUP website. There is a lot written about that. I will concise it. What is this? So first of all, as I told you, I showed you I10_DX varies from I10_DX1 to I10_DX40. So I10_DX1 is always for the primary diagnosis. That is the main reason patient was hospitalized. All the rest other things from DX2 to DX40 are either the comorbidities or the associated conditions. So Alexander comorbidity software, or any comorbidity that you generate besides using this software, are to be coded from DX2 to DX40, because DX1 is always a primary diagnosis, main reason for the hospitalization. So if you see, this is a lot, this is a like lot of the theory written over here for this Alexander comorbidity software. It is you might have heard of the Charlson comorbidity index. That can also be done, but for that I think the HCUP is not giving any software that can be generated separately, either by directly using the ICD-10 codes or the ICD-9 codes in the respective data sets, or by using that separate commands in the Stata software. But Alexander ones, we have it here. These are the archives of the earlier ones, but here you have an option for downloading the recent ones, downloading information. Once you go here, you can download from here. Keep in mind, once you download this software, this Alexander comorbidity software is only in this SAS format. You should be having some basic knowledge of using the SAS, how to run this program in the SAS. Then only you will be able to generate this Alexander comorbidity software related variables. And suppose then if you want to use this in the Stata or in the R or in the SPSS, then you can convert to the desired format later on. Okay. Alexander, I will talk about the citations later on, because these are also the important things, the citation, how to cite all these things, the HCUP, NIS, and the Alexander comorbidity software as well. Then there is a clinical classification software. So now what is a clinical classification software is that ICD-10 gives so many diseases, so many codes for, and to the pinpoint up to the sub-classification level. So it becomes like 70,000 ICD-10 CM diagnosis codes. Clinical classification software is again another software which is given by the HCUP that translates these diseases, these codes, to the 530 clinically meaningful categories. I will show you how to use that. This is a very heavy software, and it becomes sometimes very difficult to incorporate the four basic files and then the Alexander comorbidity software and the clinical classification softwares as well. Then you come the outcomes. So you have the basic four files, then you have the comorbidities, then you have the clinical classification softwares, and then you get the outcomes. Outcomes, death, length of stay, charges are already incorporated in in the 4 files, the basic files that the HCUP gives you. If you want to have another outcomes, you need to code them in using the ICD-10 codes or ICD-9 codes on the respective data sets using the I10_DX or just DX in case of ICD-9, the variables. Another kind of outcomes that you can see is the trend analysis. NIS has some limitations. The limitations important beings are the coding errors. It is an administrative databases. Sometimes diseases are the associated conditions are not coded. Sometimes there is a difference in the clinical judgment of the two physicians. So what will you take? So the treating physician puts the diagnosis code that is taken as the final code. So these kind of coding errors can be there. Then there is no lab parameters to follow. So like if you want to have the tropi, the high sensitivity troponin in the MI patients, then there is no tropi in the NIS dataset. There is no BNP, there is no creatinine levels, there is no lactate, nothing like this is there in the NIS dataset. Likewise, there is no medications, no beta blockers, no AS inhibitors, no chemotherapy, no paclitaxel. These things are not there to pinpoint your studies or to further refine or define your studies. Stages for the cancer, like there is an option for the metastatic cancer versus non-metastatic cancer, but there is no thing like stage 1, 2, or 3 cancers. So these are some limitations, and HCUP itself gives a guideline that if any of the cell after running the statistical analysis has n number of less than 11, then that report then should not be included in the analysis, or that should not be reported. There is a HCUP net. This is a smaller version of the NIS where you can actually build your primary research and get an idea if your idea is going to be successful or not. This is an online tool or online calculator. I show it here. Create a new, you go to this website, create a new analysis. This is inpatient for the NIS. Descriptive analysis, trend analysis, whatever you want to do. Let's go for the descriptive analysis. It is giving me 2018, the recent one in this HCUP net. Do you want data on specific tower? Yes, we want. Okay, choose the classification. So here in this HCUP net, it is not giving the ICD-9 or ICD-10 based, because this is just an superficial idea or brief idea what you can do with the NIS in detail. So here they are giving us the clinical classification software refined. Here you put here something like hemolytic anemia or something or anything like, or put another anemia, the acute post hemorrhagic anemia, and each code separately and create analysis. So it will show you what were the numbers, what were the total number of discharges in 2018 in the hemolytic anemia, in the acute post hemorrhagic anemia. You can combine these two at the time of refining your tabulations in the earlier field. Then the rate of discharges it gives you, and it gives you the standard error as well here. And here on the extreme life side, you can have the various permutation combinations according to research, what you want to do. You can do anything like mental health or anything, outcome measures you want to see, numbers, rate. You can delete the rate from here, take only the numbers. You can get the hospital charges, whatever you want to do. Okay. So another, once you are into writing the manuscripts, HCUP particularly states, and it is in the data user agreement as well, which you cannot overrule, or which you cannot ignore, is that you must properly cite HCUP or any of the softwares you use from the HCUP. So this is the citations page for the HCUP, and they give you guidelines how you are going to cite the HCUP or the NIS or the NRD database or any other database. So suppose you are using NIS 2019 or 2012, they have written over here. If you are using any study, doing any study on the NIS 2012 yearly data set, then you should be using this like this. This will be their citation format. This is the whole thing. Okay. If we are using before 2012 and after 2012, you are combining the data sets, then you need to have two kind of citations because they particularly state here. This format is used prior to 2012 and this one is used after the 2012. Okay. And similarly, if you use any other things, then you have all the citation, the formats, they have given the examples how you are going to cite these things. If you are directly using any of the things, the HCUPNet, you are directly building your manuscript on the HCUPNet, then they have given you the HCUPNet citation as well. If you are using any of the softwares like the clinical software, then again they have these citations, the format of the citations given over here. There is a citation for the Alexander comorbidity software as well. It is in the prior link. If you go or if you just Google the citation for Alexander comorbidity software HCUP, it will directly take you to the page and you can see the Alexander comorbidity software, what citation you need to use. So after data sets, what we can do, this is all the data set that we have. So if I before moving that, I show you one more thing on the data sets. I'm just trying to come out to the full screen so that I can open from the taskbar.
So you can try pressing escape button.
Yeah, okay. Yeah, sorry. So this is my data set here already that I uploaded. So once you upload the Alexander comorbidity software, you will get these kind of comorbidities already generated here. Okay. So these start from the AIDS. These are alphabetically organized. It starts from the AIDS and it has all the comorbidities that it has the software already incorporated within itself. So you can use these comorbidities directly to build your research cohorts, or use these comorbidities in the research cohorts to see how they are associated with the outcomes. Another thing which I want to show you is how the NIS final data will look like. It will look like this. If you load everything, it will look like this. The CMR version is here. CMR version is for the comorbidities. It is the Alexander comorbidity version which I have integrated. I did this in the SAS and then I converted to the Stata because I use Stata more and find it more user friendly. Then you have the various key elements, all these here, key elements here, and you have these. You have these in the, these are the numericals 010101 coding. If you see if you read the description of the elements, in the female, 1 is for the female, 0 is for the males. In the elective, 0 is for the non-elective admissions, that is equivalent to the emergency admissions, and 1 is equivalent to the elective admissions. So this is how the coding is done in the NIS system, and this is how you use these things to do the statistical analysis. And once you come to the I10_dx, this one, these fields, they start from the I10_dx to up to all to the I10dx40 it will go. These are the alphanumeric characters over here. And the alphanumeric characters, these are not the numericals. See the difference between these are in the black colors, these are in the red colors. These are the string characters. String characters are like the names. Though there are numbers here, they are not actually the numbers, they are the names. Why? Because ICD-10 does not give the numbers, it gives the codes. Codes are the names for the disease. It goes all up to here till I10dx40. Similarly comes the I10_PR. These are the codes for the procedures. So this is the whole data set that we have. This is the whole data set that you will get. And these are the comorbidities from the Alexander comorbidity software that I incorporated. 0 means absent, 1 means present, 0 means alcohol in this. 0 means alcohol absent, patient is not alcoholic, 1 means patient is alcoholic. It goes like this all the way. Okay. Okay, now after that we have the data set ready. Now what we need is the hypothesis or the research question. So for that, how the NIS supports us is that you can either do the single arm study or you can use more than one arms. Single arm studies are basically the descriptive studies. For example, you need to see mortality in the acute heart failure patients. So it is just the single arm study. You choose the acute heart failure from the primary diagnosis of I10_dx1 and see the mortality. How many are dying and how many are getting discharged alive. Mortality in whites with acute heart failure patients. You choose acute heart failure from the I10_dx1. Choose the white patients in these and then see the mortality there. Similarly, the stroke admissions in the African Americans and the in-hospital mortality and the healthcare resource utilization. So basically in all these examples, what you have one basic defined population. In the first one, it is acute heart failure. Second one, acute heart failure, but in whites. The third one, stroke, but in African Americans. And then you are seeing the outcomes. The third one is the lung cancer pair. The fourth one is the lung cancer patients where you are seeing the septic shock related admissions. Now, moving from the single arm, you can also have more than one arm, that is at least 2 or more than 2 arms. Then these studies become the descriptive or the inferential studies, which involve the inferential or the analytic statistical analysis as well. So a very basic thing, whenever you read any paper, you see there is a difference between the 2 arms stated in the p-value. So any paper which has a p-value, I guess it is more impressive and more readership it attracts. So 2 arm is necessary to have a p-value. You cannot have a p-value in a single arm, though you can have a p-value in a single arm if you are doing a dependency test, that is before and after some intervention. Then also it in itself becomes a 2 arm. For p-value, for the qualitative we have the chi-square and for the quantitative we have the student t-test. And to generate the p-value, as I said, you need a 2 arms, 2 cohorts. So obviously you will be having a 2x2 table. And the 2 arms will be the test arm and the another will be the control arm. So to give you an example how we got this paper published using the NIS, this is a recently published paper on the hypertension crisis related hospitalizations and the outcomes we choose as the MACE events in the base population that we had, the cannabis users. We use the NIS here and we used from October 15 to 17. Why we choose only October 15? Because October 15 onwards it is ICD-10. Before that it was ICD-9. So obviously we could have done a 10-year study, but we didn't want to overlap ICD-9 and the ICD-10 in just one paper. So it was our discussion. If you want to have 10-year, 12-year, 20-year study, you can do so, but you would have to combine all the files, or at least the codes, for generating the ICD-9 related diagnosis and the comorbidities, and the ICD-10 related diagnosis and the comorbidities in the respective files. So this was our figure 1 in this paper, and what we could find is that hypertensive crisis related hospitalization in the young adults 18 to 44 years. So in the statistical analysis in the statistical software, we excluded the observations that had more than or equal to 45 years of the age, and our primary diagnosis in this was the hypertension crisis. We went to the ICD-10data.com. We found the codes of the hypertension crisis from there, and we applied that codes to the I10_DX1. That's how we got the hypertension crisis related admissions. And then we divided into the cannabis versus non-cannabis users. These cannabis codes we applied in the secondary diagnosis codes, that is from DX2 to DX40, and generated code cannabis 0 and cannabis 1. 0 was non-cannabis users, 1 was the cannabis users. And then we did the statistical analysis and went for the, first of all, is in any paper, first of all, in any manuscript, the first thing is the baseline characteristics differences between the two cohorts. So these were the cohorts here. Blue one was the CUD negative, orange one was the CUD positive, and these were the cohorts that we have. Overall, we saw the sexual differences, we saw the race differences. The next one we had here, let me pull the full text. Okay, and this was our table for that we built up using the NIS between the two cohorts. The baseline characteristics in the young patients with and without cannabis user disorders. So all these variables, when you apply the statistical analysis, you can build the research like this. You can build the baseline characteristic tables: age, sex, races, expected payer, whether Medicare, Medicaid, private insurance, self-pay, median household income is for the socioeconomic status, non-elective admission is for the emergency admissions, admission in the teaching hospital, non-teaching hospital, rural, urban hospital, what region of the United States hospitalization occurred, and the basic differences in the two cohorts in their comorbidities. Figure I showed you. Then the second table that we had here, association of the cannabis use disorder with the hypertension crisis related hospitalizations in our base population. We had different models here. So this is called the odds ratio unadjusted we had, and then we had the adjusted odds ratio as well. So these all things are done once NIS variables you are there. Once you have the codes defined, then you should be having a knowledge of using the statistical software to build these kinds of tables, or to get your either unadjusted odds ratio or the adjusted odds ratio. Unadjusted is also called the univariate analysis, and adjusted is called the multivariate analysis. For either you can use the linear regression, the logistic regression, based on the continuous or the categorical outcome you are seeing for. This is anything this is the further advanced, this is the further statistic that we used. There was in the randomized trial, this is not a randomized trial. Retrospectively, you cannot do a randomized study. Okay, we try to go as close to the randomization as possible. So in this table, we did the propensity score matched analysis. But we had the two cohorts in the starting, the CUD minus and the CUD plus. Then in that two cohorts, we applied using the statistical methods propensity score generation. And after that, our two cohorts were balanced to study our outcomes. So if you see here in the first table, you will see some differences in the CUD minus and the CUD plus in all these things. But if you see in the table 3, if you see in the table 3, it will mostly be the p-values become non-significant, most of them. See, some will obviously remain unbalanced because of the real differences they had even after matching. These become p-values become not this one. P-values become non-significant from significant being in table 1 to non-significant being table 3. Then we move from here to our in-hospital outcomes. So NIS gives you in-hospital outcomes only. This is another limitation. For example, if you are studying someone on the pulmonary hypertension, and if a patient is admitted with the pulmonary hypertension, so it's obvious that the patient should be having at least moderate or more so a severe pulmonary hypertension. That's why patient is getting admitted. The mild pulmonary hypertension patients do not get admitted. So what you are studying is mostly in the moderate to severe conditions. So that's why we prefer to use the term in hospital outcomes. Again, we see here the CUD minus and the CUD plus things, and we did the 2 by 2 tables first. We generated the n numbers, we generated the percentages of all the outcomes and the adjusted ratios of these outcomes. Again, for the outcomes, what you have inbuilt in the NIS is the disposition of the patient, length of the patient, charges of the patient, and the all-cause mortality of the patient. Rest all you need to develop using the ICD-10 codes or ICD-9 codes. Even for the cost adjusted for the inflation needs to be adjusted. Various factors are available to adjust for the cost from the US Labor Statistics Hospital Charges website. The another thing which you can do from is there the predictors. You run the multivariate analysis and you get the predictors. What are the predictors of the outcomes? Here we have the predictors of the MACE in the hypertension crisis related admissions in the young patients with the cannabis users. When you run the multivariate analysis, then most of the demographics, hospitalization, hospital specific correctors, and the comorbidities adjust for each other, and you get the adjusted odd ratio of each of the things. So this is much that so this is what we can do from the NIS, and this is how we can get up to the final manuscript and the publications. If you are not going for the manuscript publication, then you can use NIS as well to submit to the conferences and abstracts. Yep, that's it. Okay, thank you.
Thank you, Dr. Jain. That was very insightful, and you did a very good job explaining a new database. And while we do have some questions, if you are able to answer them. So my first question would be: is this data, is this software and this Stata software available for all the platforms, Windows, Mac, Linux, or just for Windows? Like you explained it on Windows, but is it available on other platforms?
Yes, it is available. Yeah.
Okay, and what kind of a programming knowledge does someone need, like to effectively, work with this data set? You mentioned SAS data skills are required. So
SAS is required only for the Alexander comorbidity software to decode that. Because the HCUP gives that in the SAS format only, I have written to the HCUP in the past that I am more comfortable using the Stata. So do you have codes for the programming in the Stata? They denied that.
Okay.
If you don't want to use the Alexander comorbidity software, that's fine. Just see the codes of the hypertension, diabetes, or all the comorbidities you want to include from the ICD10data.com and generate that variables as 0, 1 using the I10 underscore dx 2 to 40.
All right.
Because once your manuscript is complete, it is ideal to give in one of the supplementary tables, how did you generate these comorbidities? Either you generated them using the Alexander comorbidity software, then you should be writing, for example, hypertension was available as variable CMR underscore HTN. If you generated cannabis and Alexander does not give us the code for the cannabis or the cocaine, then you should be giving them in the subsection of the table where comorbidities generated separately using ICD-10 CM codes in secondary discharge diagnosis fields. Then you list there like cocaine and give the codes that you used.
Okay. All right. Thank you,
It
sir.
is not compulsory. It is not compulsory to use the Alexander comorbidity software. You can develop all the comorbidities on your own as well.
All right. Thank you, sir. One thought lingers in my head, like this NIS database holds information about certain parameters of patient. So what about the hospitals who do not use electronic records till date? Like, is their patient data also available on NIS, or are they excluded yet?
So HCUP clearly states the hospitals which are the type of the hospitals that are excluded. Okay. The NIS, they believe from the state level goes to the national level, and there everything pulls up and it becomes an NIS. It's like this. So that I don't think so. EMR is not there. If it is like this in some hospitals, I'm not sure if they are sending their data to first to the state level of the HCUP and from there it goes to the national level or no. I'm not sure about that. But what I know is that the final product they have the NIS. And they themselves state, the HCUP state in the website, that you can use this to produce the national estimates by applying the weights.
Okay. All right. Thank you. Thank you, sir. Thank you very much.
Yep. Right.
And I think that answers all my questions. And Dr. Esha, if you have any questions, you can take over.
Hello, Dr. Jain. So someone in the audience has asked, can anyone anywhere on the globe have such an access? Likewise, for publication part, can be published from anywhere in the world?
So
Can access to this?
I am not sure. You can see the HCUP inquiry mail on the HCUP website and you can ask. I think this question is related to if you are not in the United States, you have never practiced in the United States, you have never been a student in the United States, can you still gain access to this data set or no, database or no? I'm not sure for that. Data user agreement is there. If you satisfy that data user agreement, then I think there should not be a problem. But you can email the HCUP and they will let you know if you can have that or no.
Okay. Thank you, Dr. Jain, for clarifying that. Another question is, like you said, students can have a separate price in order to register for this. It obviously must be lower compared to for other people. So my question is, are residents considered as students? Can fellows be considered as students?
Yes, I myself purchase at the student price, so I know that.
Great, great.
So you
need
to have a letter from your program, and they will ask you to email the letter or upload the letter. Basically, it is an emailing them the letter, and from there they will approve that.
Okay. Thank you, Dr. Jain, for sharing that. Another question is there any difference in the results generated through these different kinds of this, like SAS or SPSS or Stata, etc.? Is there any difference in the results generated?
I don't think so. If you keep the cohort same, if you keep the statistical test same, then I don't think so there is much difference. If you find some difference, you will find in the 5th, 6th or the 7th place decimal something because of the inherent functioning, which I am not sure of.
Thank you, Dr. Jain.
Because I have tried sometimes in the SAS and then in the Stata, I find up to like 4 or 5 places decimal same. It is also how your software is set. Default settings, you can change the settings of your softwares to give you up to the 5 places of decimal, 7 places of decimal, and it depends how you set what you see on the as an output. It will change in the last few decimal places of the result.
Okay. Thank you, Dr. Jain.
Yeah.
Another question is, can we analyze longitudinal results like rehospitalization rates using this data set?
NIS, no. HCUP itself says it should not be used for the longitudinal studies. It should not be used for the longitudinal studies, mean the readmissions, okay? It is a cross-sectional database. One observation is equal to one admission. Though the patient is admitted for 2 times in a year, still it will be counted as a 2-time admission for a patient. First of all, it is a de-identified database. You cannot know the name of the patient. You do not have the name, any personal information of the patient from where which you can identify the patient or reach up to the patient. It is designed in such way. So this is an advantage also because it does not require IRB most of the time. Still, few journals are very adamant and very strict that they need IRB and they do not accept NIS based papers then. But it's just, I think it's just like a couple of journals only. You have the whole world of the research journals which will take these papers.
All right. Thank you,
For
Dr.
the
Jain.
longitudinal study, you have a different database, that is the National Readmission Database.
Oh, okay. Thank you, Dr. Jain, for shedding light on that. If our audiences do not have any more questions, we can take a 5 minutes break. So I would ask my audience to pose any questions if they have.
I think there are no questions, Dr.
Yeah.
Esha, and we can conclude the session. We can take a
Yeah.
5 minutes break. Thank you very much, Dr. Jain. It was
Thank you,
very
Dr. Jain.
insightful and very interesting session. Thank you very much.
Thank you. Thanks a lot.
Thank you.
Thank you. Bye.
Thank you, Dr. Jain. It was really helpful.
Thank you.
And we can all get a 5 minutes break and we'll start at 3:02.